It's great. It's great to be back with you all. Again, I so much wish that our first part had been in person, so this would be much more of a reunion, but I will pretend that this is a reunion, and we are here to be of help in however we can, so don't hesitate to reach out. Again, I'm going to present. Zoom makes it hard, but this is a discussion. If you have questions along the way, let me know. Ashley and Michael, if you see questions in the box, just let me know.
Yep, absolutely.
I'm going to put some slides up then. Hopefully people can see them.
Looking good.
So the most of today is going to focus on the analytic approaches of quality improvement. We've all advocated to you that in your career, you need to do lifelong learning. As an epidemiologist, I now teach about needs assessment and planning. I also now teach about quality improvement because in our careers, I've had the opportunity to need to learn all the way along. And this is one where I quickly learned that the training I had and the experiences I had didn't relate to really how quality improvement works with the data and statistics they use. So this is some fairly basic stuff. I did send you 2 articles that support the methods and approaches for your own knowledge. Hopefully they're helpful. I do want to acknowledge that I borrowed some material from Deb Rosenberg and Ashley Harari and Judith Shaw, Lloyd Provost, and I really want to give special acknowledgement out to Munish Gupta because a lot of these examples come actually from Massachusetts, and he was gracious and said that I could use these, and so I take advantage of them. One of the things we do in the quality improvement world, we encourage you to do is we beg, borrow, and steal shamelessly from one another all the time. So hopefully you will learn from each other because it's best to learn from each other than by mistakes. So let's talk about the audience. If all of you are on the call, about 8 of you have no experience. 23 of you have basic experience, 18 have intermediate, and 2 of you have advanced, which is great to see. And what I'd like to do is I'm going to ask you a question. I'm going to show it on the slide, and then I'll put the screen down. And what I'll do is I want to look at hand tallies. I really want to know what your knowledge level is like. So there's 5 lessons of questions. Have you ever seen a run or control chart? Have you actually ever used one for programmatic or quality improvement? Then the next level up is, do you actually know the statistical rules on how to use it? 4, do you know how to generate it? And then 5, are you a Jedi Master and should you be giving this lecture instead of me? So what I want you to do is we're going to just start out with that. And if people would raise their hands. So how many of you have actually ever seen a run or control chart? Not just in a classroom, but actually seeing it. Raise your hand if you have. And then we'll put hands down as I go further along. So only a few of you have actually ever seen a run or control chart. I see 5, 6, 7. Only 8 of you, 9 of you. Okay, and how many of you have actually gone ahead and actually used it for a program or for an initiative? About 6 of you. And how many of you have actually generated and used statistics on that control chart? And how many of you want to give this lecture? Okay, Becky, I'll just advance the slides. Let me go back.
I could not find the hand down button. I'm good though. It's all yours.
So it seems like there's some stuff to cover. So we're going to talk briefly about and go over again what is quality improvement. What role does data play? Does epidemiologists relate? And even if you don't do quality improvement yourself, do you really need to engage in quality improvement and play a partnership? Oh, how does a run chart work? How does a control chart work? And then we'll give you some examples and we'll ask you some quizzes. So let's get started. The first is, I'm not monitoring, I cannot monitor. Did you look at the free web training? If you're not really familiar with quality improvement, both of these webinars are well done and professional. They're not someone talking to you. It's designed as an interactive online training piece. They're excellent. I would encourage you to use them, and I would encourage you to share them with the people on your team who do quality work if they are not used to it. And NicheQ offers these free. It's a great service by them. They're a great partner. So when you talk about quality improvement, QI really asks, or sometimes it is really differentiated by epidemiology by asking two fairly basically different questions. Generally in epidemiology and public health, we ask about, are we doing the right things? Are we doing evidence-based public health practice? But really, quality improvement and program evaluation look at a second question. Are we doing things right? And I will tell you, with many of our efforts in public health, it's not about did we choose the right initiative. We haven't implemented them fully. We have not taken full advantage. And that's the idea of what quality improvement and potentially program evaluation is trying to answer. So it's really helpful to think about these two questions as you go into what you're working on. So in terms of quality improvement, the IHI cycle that's that's really famous really talks about, so what is it you're trying to accomplish? Be very clear in defining what it is you're trying to accomplish. How will you know that a change is an improvement? In other words, you're trying to accomplish something. How do you know that a change is an improvement? And what change can you make that will actually make that improvement happen? And these three questions are questions that you ask in a quality initiative over and over and over again. And we do that through what we call a plan, do, study, act cycle. There are about three major disciplines of quality improvement. They each use different names, but they have the same 4 steps. First one is you figure out you have an idea that may work, you plan it, you carry it out, you do the thing, you quickly learn from it, and then because of what you learn from it, you change. Either you make the change you're working on different or better, or you decide to expand it and enlarge it. And you do this again and again. And so it's called small change, a small test of change over time. The idea here is we may not know the right answers, but that we want to go through a process that iteratively gets us to the right place to create the change that we want to see. So you think about quality improvement as really an ongoing dynamic. So how do we define the change? And again, a lot of this is covered on the webinar. I'm just trying to remind people. We do that by coming up with clear drivers of the change we're trying to have. We look through the literature, the evidence base, and the practice, and we come up with a SMART aim. Again, something that's measurable. What is it that we're trying to improve? In our example today, we're going to talk about the percentage of very low birth weight infants in the ICU that gets human milk. And then the way we're going to measure it is at the time of discharge. We know that human milk, not only just for babies, but for premature babies, reduces infection, improves growth and nutrition, and actually leads to shorter NICU stays. So it's a very potent intervention. More importantly, if we can actually get mom to eventually move to breastfeeding, it actually helps with that transition of an NICU baby to home. So if we know what our aim is and what we're trying to do, then we try to choose what are the major drivers to create that change. And for this initiative, we're going to talk about, one, we need to give education to the family to understand about breast milk and breastfeeding and how do you provide milk to a newborn baby, especially one who's very low birth weight. And that education piece is important. Then we talk about how do we get human milk production started with the mom? How do we continue that well? And then how do we get the staff at the MSU to buy in and to help make this happen? Because they are the gatekeeper and the broker, they are the promoter, and they're the coach. And so once you've identified those 4 primary drivers and you go into your secondary drivers, what are those things that you need to do to drive those primary? So here we talk about antenatal consultation, telling them, the parents and the family, about the need for breast milk even before the baby's born. And with initiation, we work on more pumping, and we work on pumping even earlier within an hour of delivery, and we even consider donor milk. With continuation, we find that skin to skin is very good at helping to bring mother's milk down, and it helps the baby as well. And then we also work on other pieces. And from there, you can have activities that lead to those drivers. So we actually try to put on paper what change we think we can do, and we test it out with our quality improvement process to see if things are changing using small tests of change. So the importance of data in QI. In fact, without data, we cannot do quality improvement. The way we frame it is what gets measured, gets done, or gets managed. And if you're not measuring, it's likely not happening or not happening the way you think it is. And so measurement and quality improvement is always important because that's how we test change. That's how we know that what we're doing is making a difference. In terms of planning, we use the data to actually help us understand the problem and then to help work on selecting our strategies. And then we use data in that iterative process of plan, do, study, act. We use it to iteratively evaluate. We use it to look at what's effective and what needs refinement. And then we'll even use it to explore variation and what may be opportunities that we can change. So data is part of the primary engine of quality improvement. Now, the hard part for EPIs, and it was for me at least, is understanding that QI data is really typically different from epidemiology. I mean, there's commonalities, but there are some subtle and not so subtle differences that are important. One, in quality improvement, you are always collecting data continuously over time. And in fact, it's important that you get timely, quick data often. In EPI, for example, with your birth files, you'll have to wait till the state closes it down and it's finalized, and then you can do something with it. Or you'll be waiting for certain periods of time. In quality, you need it to occur immediately. Data generally is displayed continuously. So you are always looking at your data over time, and almost everything is in an over time format. The time intervals are very short. Generally, they're quarters, months, even down to days. The sample sizes are small. In fact, as epidemiologists, I would tell you they're uncomfortably small. With some of our initiatives, we've measured as few as 5 events in a month to get an understanding of what's happening with quality improvement. You don't really use a comparison group. You usually compare to historically over time. It's done using simple time series statistical rules, which are different than the typical biostatistics that we've learned. It's heavy on process. It's not only that we want to improve the outcome, we want to know, are we making the process changes what we thought would work to improve those outcomes? Because the outcomes aren't going to change until our processes change, and if they're not the right processes, until we get the right ones. And then it not only focuses on results, but we also want to look at variation, because what we learn over time is our variation tells us the clues to what's working, what's not working, or what might work. Now, when you look at it, it's really different from performance measurement, research, and evaluation. The aim and the purpose of a PDSA, quality improvement training, is to improve the process, to improve the outcomes. In performance, it's about accountability, and research, it's generally about generating new knowledge or knowledge that's going to work in terms of a program. Your audiences are different. In terms of improved quality improvement, it's a program manager versus a funder versus society. The scale, you use small units of change in a system. In performance measurements, you usually have large population units. In evaluation research, you can have some of either. Timeliness. In quality improvement, you need real-time, quick data that can lead to change. Performance, you always want final or annual data. And frequently in research, you're looking over time till you get the right sizes of what you need for your evaluation. Bias is another big area. In quality improvement work, we'll actually accept bias, especially if it's a consistent or stable bias. Because what we're looking for is change over time. So we don't care if the measure is perfect. If it's approximate and it's consistent over time, we can see if change is happening. With performance measure, you want to try to adjust and reduce bias, and in research, we try very hard to eliminate it. For comparison groups, again, QI work, it's usually internal, it's historical. Benchmarks are also, for performance, are historical, but frankly, benchmarks. And then research, we try to randomize or do quasi-randomize, some way to try and control. Sample sizes, we just want just enough and we don't want to burden people. Performance, you want to get 100%. And in evaluation work, you get just in case. So our hypothesis in quality improvement work are flexible. We'll change what we're trying to do. We'll change our measures. We'll change to do whatever we need to get the improvement we want. Where in performance measure, you usually have to meet objectives. And in research, you have a fixed upfront hypothesis that you're trying to test. And otherwise, you do a secondary data analysis. That's totally different. In quality improvement work, we focus on run charts, control charts, process charts. Performance measures, it's really looking at measurements over time, not really tested. In research, we try to actually make sure we have good precision on our estimates. So they're really, really different from each other in various ways. We have some commonalities, but how we use, what we use changes. And as I've been in both worlds now, I actually use the strength of both in both worlds because there's advantage from each side. Now, when you integrate QI and epidemiology, there's some lessons here. QI actually provides impetus for population-based data more timely and accurately. For example, in Florida, we are now able to get birth certificate data within the end of a month, with 2 weeks actually. So if we're working on our NTSV cesarean rate project with hospitals, we just got through and just got into November. We'll have our birth certificate data in about a week and a half on what our October rates are. I do know states who are still 2 years behind in giving access to epidemiologists to their birth files. So we use them almost immediately. We use our hospital discharge data in 6 months, and we're part of the group that's really pushing the state to make it even quicker. Timeliness is extremely important. You can't get people to change their performance on data that's over a year old. That is very hard to see what's really happening and whether what you're doing is making a difference. And our epi friends are very happy that we've done that because now everybody is getting quicker and easier access to data so it can be used. Our public epi approach really provides impetus for our quality initiatives. We basically have been using our maternal mortality review data for years now to help us select the initiatives that our quality improvement collaborative is going to work on. And in fact, we just got through choosing our next 2 initiatives, and up front were the results of our maternal mortality committee. And we basically use the 2 approaches now synergistically so that one feeds the other. And by being an epi, it's actually put me in a pivotal place to help some of that actually take place. And then there's really an integration of quality improvement and epi. Quality initiatives can identify quality issues in population-based data sources. We are able to tell vital records when hospital birth certificate data looks now corrupted. And we talk to our vital statistics people, and they work with the hospitals to immediately correct the errors that are in their data. And in fact, we're now running birth certificate trainings with our vital statistics people for hospitals across the state to train them to better report the data. We also perform a lot of the analysis that we need to be looking at a larger population-based level. On the population-based side, we use that data to help prioritize our quality initiatives. We use that to monitor whether our quality initiatives are having population-level impacts. And then we can use that to give sort of different programmatic experts to what we're trying to do in our quality improvement initiatives, so it can help refine what we do. So there really is a nice interface, an interplay that can work out here. So why does an epidemiologist want to even be interested in this? What's the role of an epidemiologist? You all thinking of patterns and trends in terms of public health and epi are really valuable to quality improvement people who may not come with that mindset. You all will help us apply comparison groups to see, oh, you had that improvement. Well, by the way, all the other ones had this same improvement, or they had less, or they had more. So that you can actually help provide a better picture of what's going on with quality improvement. You can help better with our numerators and denominators, because sometimes on the quality side, we're willing to compromise, and you all can encourage us to have better data. We do small sample sizes. At times, EPIs encourage us to look at things, and maybe we need to have more stable estimates. So we try to figure out a balance. You actually help us look at some of the intermediate and long-term outcomes that we don't always look at in quality improvement. And you can also help with the idea that there are risk factors and drivers and other things that may be taking place in our QI initiative that our simple QI data will not pick up on readily. You can identify our priorities. You can justify the need to work on quality. You can connect those analyses. You can assess our impact. You can select measures. Again, you can assist and work on accurate data that we're all interested in, and you can design and test reporting mechanisms to see if all those efforts we're doing are actually improving. So there really is a role for epidemiologists in quality. And if you haven't seen that yet, my hope is that you will, because it's hard to imagine that in every role, you should not be encountering quality in some perspective, just like you would program evaluation. That's just sort of a brief overview on quality, the process of what it does, and some of the roles and integration with public health. Are there any questions about that before we start getting into analytics? Questions, comments, thoughts? We're quiet today. All right. We'll continue on. Of course, you're going to go back to the wrong place. All right, so now let's talk about run charts and control charts. You're now entering the trend graph and the quality improvement world. And there are really two types of graphs. There are run charts, which refers to the consistency in points, not a consensus number, but typically at least 5. You're looking at continuous points that are above or below a median. You're looking for a monotonial increase or decrease. It's a very, very simple chart. On a control chart, you're trying to make it more statistically sound. So you're going to now add some limits to it. You're going to add boundaries, and you're going to deal with means and standard deviations. So one is a very basic monitoring chart following very basic rules, and one tries to be more statistically precise. However, they both have their strengths and weaknesses, and we'll talk about which ones you use more often near the end. So how do you look at variation over time? Both of them will graph over time. However, with control charts, you actually may choose to graph over subgroups, and I'll show some examples at the end. Your center line in a run chart is the median, or in a control chart, it's the mean. In the run charts, you have 4 sort of chart rules that you follow that follow time series statistics. So you don't actually run statistics. We can tell you some basic rules that will tell you what is significant and what is not. What's nice about that is you can teach people in your programs and the quality people that you're working with these basic rules, so they don't have to be, quote, statisticians. They don't need a computer. They can look at it visually and make some decisions. With a control chart, we actually have upper and lower limits, and then we have 5 rules. And then we start talking about this idea of common and special cause variation. So I mentioned in quality improvement where it's not only important about the estimate, but it's also important to know how that estimate varies over time. And is there a special cause for change, or is there some change that's happening? It's happening, the common variability that's there. And we'll talk about both of those. I like this cartoon because it really highlights. I'm not superstitious either, but those 3 days, Harris wore his socky socks. So those are the days sales went up. So let's talk about run charts. And let's just focus on run charts. Those are the easiest, basic. And for me, those are the ones I use more often. And I can tell you why when we come to that point. Run charts. It graphically displays the data over time. It's very simple to make and use and interpret. In fact, we encourage you to keep the graph simple, because this graph is not for the data people. This graph is for the health service providers or the program to be able to use themselves. Again, and you plot it in some order, usually over time. It lets you communicate and understand the variation that's happening over time. It provides key measures that you need to look at that need to be visible, that everyone's tracking. It determines if the changes you're making are improving or not improving. And it can illustrate whether if you've had that improvement, we talk about holding the gains. Okay, you improve, but are you sustaining it, or is it really a one-time effort and you're not continuing that? And we like to see sustained improvement. And so when you look at a graph here, you've got your observed data over time. Your y-axis looks at the value. Your time is on the bottom. You have your line. And then those little boxes there are when you did some change or something happened and you want to see the impact on your measure. So you're going to look over time to see if those changes that took place are really creating change in this measure. So what are the basic steps? You select a measure, you figure out what your axis is at the bottom of its time, what's the time period, if it's a sequence, what's the sequence. On the y-axis, you want to have enough space above and below the line to make sure that you can have variability and not have to change your axis all the time, because that throws off people. You want to plot the data, you want to label the graph and everything. You want to calculate and add a median. And that's just something we're not used to in EPI, is adding a line, but a median is always on a run chart. You cannot use a run chart without having a median. You annotate when your changes took place, or if you have a goal line you're trying to reach. And then you can show direction arrows if things are unclear. Now, when I talked about making the graph simple, you want to avoid things like grid lines that give you too many lines. You don't want grid lines. You don't want regression lines, because regressions don't use the time series process most of the time that we're talking about. So this is where we're saying less ink is best. The simpler it is, the better and easier for program and health service people to understand. So they're basically 4 rules. We'll walk through each of them. One is, if you have a median, do you have a shift? Do you have 6 points above that median or 6 points below? Do you have 5 points of going up or 5 points in a row of going down? Do you have too many or too few runs? What we mean there is it crossing the median too many times or too few times? Do you have the right amount of variation, too much variation, too little variation? And then do you just have an outlier? And you're all used to outliers. So we'll walk through these. So a shift is, again, it's 6 consecutive points above below the median. If you have a point on the median, what you essentially do is you ignore the point. It doesn't count towards the 6, doesn't count against the 6. You just ignore that point. So you just sort of skip that value. So here, if you look at this graph, it's the average wait time per day in this clinic, and you can see what's happening in the wait time. They had a lot of variability, and they started to work on it. This is again nasal, so maybe this is the medication one, sorry. So they're using medication, they switched to a nasal dose, the medication became a lot easier, and they were giving it in a shorter time period. And you can tell you got 1, 2, 3, 4, 5, 6, 7, 8 points below the line, so that you know that that's improvement. Rule 2 is 5 consecutive points, and you can run your own probabilities on that. It's 50-50, and you go and you exponentiate that 5 times, you'll find it statistically significant. That's what this one essentially does. And you can see if you've got at least 5 points in a row, that's going to be a statistically significant trend. This last one is an intric one. That was a very new, strange concept to me. The idea is that if you have random fluctuation in your measure, it should be crossing the median on a fairly regular basis. And we can actually put confidence limits around how often it should be changing. And it's based off of the number of observations that you have. And so we should be able to say, okay, if this is normal or random, it's within this range. If you have more than this or less than this, then something else is happening to your measure that's not random, causing it to vary more or less. And you'd want to know what that is. Again, if it falls on the median, you ignore that point. It is neither crossing or not crossing. So if you look at this graph and you see what's going on, you can quickly see here by the wait times per day, this one is there. You can see quickly that there are some points there. Again, I want you to look at the rules. Tell us what you think. Is this a trend? Is this is there a rate issue going on? Is there an astronomical point? What's going on here? Can anyone tell us what's going on? You'll actually find that there's very few runs. This one right here has 1 and should have far more. There should be 3 to 9. There should be have been between 3 to 9, and you only have 1. Does that make sense to people? This that median and crossing it should occur on a random basis if there's no pattern. And this one essentially just crossed it once. The last is an astronomical point. Again, it's an outlier. If you see something that's out there, you may want to know what was unusual on October 18th and try to figure out why that was different. That could be a positive, it could be a negative, but you just want to have some understanding. Again, that day, 3 staff members called in sick, and so the wait times got worse. So this is a feeding, first feeding of human milk. In other words, what we'd like to do is get a certain percentage of these feedings within an hour of birth, or within a certain, this is feeding. So this would be within, we'd like to get that first feeding within a certain time period when the baby is now able to feed. Obviously, some NICU babies are too sick, but once they're eligible to feed, we want to get that human milk there within a certain time period. And this is percent of all that got that first feeding as with human milk. When you look at that, I want you to interpret that. Is there a shift? Do you see 6 points on one side of the median? Is there a trend? Are there too few or too many? Is there an unusual point? Or is there just really no variation here? What do people think?
Again, you can come off of mute or you can utilize the chat. I am monitoring that.
What do people see here? I got a chat.
Too few.
Too few medians across, okay? Let's see what the answer is. Ah, you're correct. There were 2. There should be at least 3. Why isn't there 6 above the line? You could argue that that 1 point right there is not quite on the median, but it's below the median, so there are not 6 points. So there are not 6 points. There's not a clear trend of 5. There are not really any outliers. It's really that there's too few of runs. Again, to me, that is a new concept. It is hard for me to see and pick up, but it's very valuable. That means something is going on here that is changing the variation and not making it happen. So something happened between April and October that's causing the variation to improve and now get worse, where before there really wasn't much variation. And what was it? Here's another one. The team launched a new initiative at this point to try and improve that first feeding is human milk. What is the change? 6 points on one side of the median, 5 increasing points, too few or too many runs, an astronomical point. What do you all think? I've got 1 vote for 6 above the line. Others? I got another shift. Yep, there's 6 above the line. 1, 2, 3, 4, 5, 6, 7, actually. So that would show a shift. So that really means that during that time period, there was a significant improvement. And you would want to learn, so what happened? It probably relates to your initiative. If it's falling off and you're not sustaining it, you'd want to learn, why are you not sustaining it? Because it did work for a time period. It looks a little rough. It doesn't look pretty because you got a lot of variability going on, but this is how you can tell whether you've had a real change or not a real change, given the variability that's going on. And it's nice. You and I didn't have to sit there and go back to a computer lab and run numbers on it. It's something that you can teach others on your team to do without having to use you all the time. Run charts. It is the minimum in a quality improvement project. You should do at least a run chart. If you're not doing at least run charts, you really are not doing quality improvement because you can't tell what's going on. You're just going to start making your own guesses. You can start with a few points. The basic rule, I've got a colleague who's our quality lead, and she says, Bill, if you got at least 6 points, you can probably start a run chart. In fact, she'll have us do a baseline for a quality initiative based off of 6 points. And we'll look at that baseline for change. In theory, for those statistics that I just told you, for those 4 rules, you should have at least 10 points. I'll say it again. For those statistics to work, you need at least 10 points. However, if you're seeing something happen in less than that, it may and likely be statistical, and you'll see it over time. They're very simple to create. They don't require any special software. It can be done anywhere. You can use all types of data. The key is it's not as powerful, it is not as statistically rigorous as a control chart. So let's talk about a control chart. So if that last one is what I would call the Ford, we're now going to start trying to look at the Lexus here. And so I use that because a lot of QI work we do came out of Toyota. But now you're talking about a statistical tool that distinguishes what we call common and special variation. Far more rigorous. you have a center line with a mean, and you have an upper and lower limit of 3 standard errors. Now, I must tell you right away, the standard error calculation we're talking about here is not the standard error calculation you learn in biostatistics. It is a very different standard error that you use in a quality improvement time series chart. In fact, I tried to be cheap and see if we could create our own on Excel. And I was clearly shown that our our error rates would not work in any way for these charts. The challenge with a control chart is you need 20 points for the statistics to count. And for us and our Forward Period Quality Collaborative, most of our initiatives only go 18 months. You have baseline data, that's 6 points. So we really can't use control charts until we're really far along in our initiative to go back and evaluate change. It is not something that we can do early and frequently in our initiative. It's something that we can add later. But if you publish, these are the standard of what they generally would expect you to do. They would expect you to try and have control charts if you can. Now, the control charts get to be complicated. As soon as you say statistics, there's not one control charts. If you look at this graph, you'll see there are 5 control charts. There's a C, there's a U, there's a P, there's an X and MR, an X bar, and an S. Why do we have that? As you know, in your statistics, we have different statistics for discrete data versus continuous data. And then we have subcategories of discrete and continuous. And so to do run charts, they have different confidence limits that need to be run. The means are generally the same, but the standard errors vary. And even the number of charts vary depending on what type of data you have. So this requires you to actually think. This actually becomes a worksheet if you're trying to do it for you to figure out exactly which charts you're supposed to be looking at. There are 5 rules. 1, if you have a data point outside of your standard errors, your control limits, that's special cause variation. Now, with a change over the mean, you need not 6, but 8 consecutive points. For a trend line, you need not 5, but you now need 6. And you can have almost out of range. You have 2 out of 3 consecutive points near the limits with it, more than 2 standard errors, but not quite 3. If you got 2 of them, that would show something's happening. And then instead of these runs back and forth, what we try to do is if you have 15 points that are really in a narrow band compared to all the other points, then that would be something happening with your variation. So those are your 5 rules for a control chart. Slightly different and important. So when you look at this piece and you try to say, okay, is that a change over time? We talked about it earlier. We had the 6 points above for a run chart. Well, the first thing you'd have to do is decide what charts you would run. So for this data, first human milk, if you remember the indicator, who wants to tell me what chart you would read? What chart would you use? Would you use a C, a U, a P, an X, an MR, or an X bar S? Some of you have been good in putting answers in the chat. That's fine. Just tell me which chart you think. I'll be honest, I didn't get it right the first time. This is not as easy as I thought it was. I have a P. Does everybody agree in a P? We got 2 Ps. All right. It is. 1 is discrete data. 2, we're classifying whether they did or did not get breastfeeding. Doesn't matter whether it's equal or unequal, it's a P chart. Well done. Good try with a C, but it's not really a count. You're really classifying. A count is a number of events counted. So it's a little bit different. So here is a control chart for this measure. Here is your mean in blue. You can see each of the standard errors that are there. The team launched an improvement here. Do we have a significant test here? Yes or no? With your 5 rules. Remember, it's got to be 8 points above the mean. We only have, that one's not even above the mean. We only have 5. So there is not special cause. So with our run chart, we said there was. In our control chart, we said there wasn't. Now let's do some counting. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So there's going to be more than 20 points. So the statistics hold up. So this is where our control chart may be a little bit better. What happens is a run chart somewhat errs on a type 1 error and saying something is real when it's not as real. And that's why the control charts are better. But again, the problem for me in quality improvement is it takes a long time for us to get 20 points. So we usually cannot start there. And so it's one we do more in evaluation late in the initiative and not something we start with. So let's look at a different measure. We've been looking at first feeding as human milk. Now let's talk about a measure here called moms pumping earlier. And so we're now going to look at the time to first use of human milk for oral care. When you have a baby gets that first milk, the mom's milk has colostrum. In it is a whole series of valuable antibodies and other enzymes and attributes that babies can benefit. So we want to get that to the babies early on. Even if they don't really eat it and we just paint it in their mouths, it can change the whole biome. We're now learning that the biome in the mouth and the gut are very important. And this first human milk is important in the earlier. So the time period to using it, the earlier matters. So here's the data. You always want to see the data. Well, you now have it. The number of hours until they got that colostrum to the baby. You can see how many on each of the different months, how long it took. So if you can't guess, the next question I'm going to ask you is, what is the right run chart? Is it a C? Is it a U? Is it a P? Is it an X? Is it an MR? Is it an X bar or an S? Which chart do you use now? We may have to give bonus points if people get this one right. I have a C. I have a U. I have an X and MR. A lot of agreement here. Drum roller. Well, first, it's continuous data. It's how many hours, so it's continuous. It could be any of those data points. It's not discrete. And they had unequal group sizes. They were not all in the same group sizes. So in fact, it's really an X bar and S chart. So let's look at that. Why is an X bar and an S? Because you actually get 2 charts in this control chart. The first one talks to you about the mean and what's happening in the mean. The second it tells you what's happening to the standard error. So the mean lets you look to see whether you're seeing overall improvement in your measure. The second one says, how about your variation? Is your variation increasing or decreasing? And that's very important. Why does it matter? Because if it's a good quality process, Wouldn't you want someone to do that good quality process more often and regularly? Or do you like it when it works sometimes and not other times, and works sometimes and not other times? The whole idea in quality improvement is you want every mother and baby to be able to take advantage of that colostrum early. And so this graph lets you see what's happening to the measure, but also to that variability. So again, you're looking at you're looking at the mean, you're looking at your two humps and how do they vary. And the other one, you're trying to look at, is that variation wider or deeper? Hope that makes sense to people. So you're looking at both. And a continuous data gives you that added dimension. Why does it matter? Because you can have the mean go up in this first example and have no change in your standard error, or you can have no change in your mean. However, you can get less and less variability. So at least you have less bad or less poor performances. So in our example here, let's talk about tests of change. For the X bar, do you see any special variation or common variation rule changes? Of your 5 changes for a control chart, what do you see in this top chart? Any rule differences? Hopefully you're seeing there's at least 8 points here. In fact, there's more than 8. And that's below a mean. Remember, this is mean and standard errors. So these are means and standard errors, and there's 8 of them. Now, if you look at the S bar, what do you notice with the S bar? Did both improve? Did one improve? Did all of them improve? The key gets to be is both improved. So not only did we get them oral care earlier, we did it more consistently, which is exactly what you'd like to see in a quality initiative. And you can tell them we did better, and we did it better more often. So why control charts over run charts? It's more sensitive, more powerful. It minimizes that type 1 error, that false discovery error, estimates the capability process more accurately. However, that however is not, as you notice, is in bold in a different color. It is more difficult to generate, and it requires more data points before you can apply those rules. So in theory, if you think about it in a quality improvement world, you should find yourself using some of both, depending on which offers you the best advantage. Now, with those control charts, what we didn't talk about is you can look at them over time, but you can also look them over other units the same way. You can look at them by different geography. And that can be helpful, actually, statistically, when you're trying to compare multiple places like states or counties or other pieces, because they may actually tell you some stories in the variability that you're not seeing. Give you an example. This table, infant mortality 2012, looks all over the map, not quite sure how to use that. But if I take that and now put it in a more of a pyramid chart, I can now put those with low volume, low number of states to those who have very large states. So what does this newer figure tell us, guys? Is that helpful? It lets you quickly see who's doing better depending on their sizes, and lets me look at the variability instead of trying to put everybody on the same scale. Yeah, I can do confidence limits, but this is a whole lot easier to see who are the outliers outside the range than to look at the confidence limits for each of these states and figure out how much they vary from each other. So this can be a very powerful tool. And then I can take this and I can go to the next step, and I can look at it by race ethnicity. So then I can quickly figure out which states are doing well or less well with their different subpopulations, and it breaks it out by their population volume so that I can look at low number states versus high number states and who's out. So again, this is a great example of how you can use control charts to not only look at time, but to look at other issues. Again, we'll hone in on the black. This would quickly let us know if we're all trying to reduce health and promote health equity and reduce racial disparities. You can now quickly, easily spot which of those states that are in the lower range and which of those states are in the upper range and where they fit on the population basis. So you can't argue that, well, ours is higher, but we have variability compared to others because we don't have that many. This sort of takes that variability argument out. Now, the other thing is when you can look at infant mortality rate, we have a tendency to look at trends. We come up with these assumptions on our parameters of what that trend is, whether it's log linear or whether it's linear, and we try to measure those changes. We could actually go a step further and use something like a U chart and actually look at the SIDS rate. And what we can start talking about here is not what's the trend, but are we keeping our rates down? Are we bringing them up? Did they change? This gives us a new dimension. So it's not only about the trend up or down, but it's how the trend is changing over time and whether we're sustaining it, the gain, or losing the gain. Again, adds another dimension to think about in your time series analysis. So we have these limits, and we have a control charts use limits and periods of time, and so do the run charts. How do you know when to change those time periods to switch your parameters for your control charts and for your run charts? Again, when the trial limits have been calculated are usually then fewer than 20 subgroups, you may want to recalculate them as you get up to larger groups. If your initial control chart that you ran has some special causes and things that are going on, you might want to redo the analysis later in the future so that you can see if that pattern is changing and getting better limits. If you have an improvement and that improvement is a result in special causes, you now may want to say what's happening after I made that special charge. Okay, I have those 8 points below the mean. I now want to start out a new time period to see what's happening in that time period and not hold on to those 8 points. And then if your control chart is unstable for 20, you might need to do some other breakups. So again, there's an art to this in trying to decide what are the time periods, what are the intervals for your run charts and your control charts, and when do you change that median, and when do you change your means and your errors. Again, here's some other population bases. You can see here in California that when you assume some change here, they didn't assume any change over time here. You can sort of choose when and where you think those may go. So that's bringing us to more of a wrap up. Some of the lessons. Remember, what gets measured gets done and managed. But the other problem we have in quality improvement, I have in our state with our hospitals, they send us their data so that we know what's going on, but they haven't done anything to create change. So we have great data to show they're not changing anything. And so I like this, but you don't fatten a cow by weighing it. Giving your cesarean data doesn't tell us you're working on reducing your cesarean rate. It just tells us you're giving us data. For quality improvement, it's not about judgment. In fact, with QI, you want to increase your failure rate. You want to try things differently so that you can see what's really going to work and make a difference. It is about testing out new change. We talk about working smarter, not harder, do small tests of change. And you'd like to make those mistakes early and not in big. So we take small tests of change, test it with 1 or 2 people, check it with 1 unit, check it on a small scale, see if it works, and then expand it so that you can learn quickly on small errors instead of learning, oh, we did this multi-million-dollar initiative for 2 years and it didn't make any difference. And then the last thing that we really do, and I mentioned early on, we share seamlessly and steal shamelessly. I'm using these slides from Massachusetts. We share stuff all the time. We just produced a video clip now on a mother who died almost 3 times and was saved by naloxone. And many states could use that testimony as a need to give naloxone to keep our moms alive. So we share and borrow and steal shamelessly and encourage everyone in quality improvement world to do the same. Now, there are software packages you can buy. We can't quite afford to do the SaaS one regularly. We're trying to do Power BI right now. And Power BI has an extra module we can't quite afford, so we do some of our own work. You can also, Q Macros is a software that will let you do it for an Excel spreadsheet. It's very cheap. So if you can't afford any of these high price ones, you can get something like a Q Macros. This may be out of date now. There may be some better ones out there now, but there are some cheap software things that help you do your QI statistics. There's some sophisticated ones, but remember, you can almost do a run chart with anything. That brings us to questions, wrap up, thoughts, feedback. Again, quality improvement work and doing statistics with quality improvement work is very different than what you do in a traditional EPI, but has great power and can be quite a useful tool, not only in the healthcare environment, but even with our programs, because many of our public health programs should be working on quality improvement because we're not always doing the best that we can do. Well, it's Tuesday. It shouldn't be too much turkey. You should be able to ask questions. Well, I don't see any, Michael and Ashley. I'll turn it over to you guys.
Mike, do you want to start?
I mean, I don't really have anything other than to say thank you, Bill, and that it is great to see everybody on Zoom again.